Hi guys, welcome back. The next topic we're going to study is symptomatic bradycardia with a pulse. If a patient of bradycardia is not having any symptoms, then there is absolutely no treatment required for the case. Let us take an example. If I have a professional marathon runner, then this guy will be having definitely a high vagal tone, and as a result of it the heart rate can definitely be less than 60, maybe in the 50s also. But there is absolutely no treatment required for these patients, since I highlighted that these patients would be having a substantially high vagal tone. But now, if I take a person who's suffering from hypothyroidism, you would have read that hypothyroidism patients can also have bradycardia. But if there are no symptoms in a patient, then there is definitely no need for treatment. It's only symptomatic patients. What are going to be the symptoms? They could range from dizziness due to low blood pressure, altered mental status, and even chest pain. Well, why chest pain? Because you see, in bradycardia, cardiac output would be less, so coronary blood flow will also be reduced, and this reduction of coronary blood flow can result in chest pain. And lots of time in the exam, from the symptomatic bradycardia perspective, he might even talk about a patient of inferior wall myocardial infarction, where there would be changes in lead number 2, lead number 3, and AVF, and there's going to be concomitant bradycardia. In the MI topic, I've highlighted an inferior wall MI. They can be vagal activation, which is present in the wall of the right ventricle, and thereby bradycardia can actually contribute to a substantial fall of blood pressure, and we might even lose the patient as well. The first message that I'm giving is, if a person is asymptomatic from any of the two scenarios that are currently jotted on the board, there is absolutely no treatment required for the patient. In contrast, you should always be having to evaluate bradycardia in the ECG. Suppose he gives you a scenario of MI like I highlighted earlier, then you should be quick in evaluating the heart rate of the patient. Like in this case, I'm just jotting down the number of large squares. In fact, every time I have discussed about ECG, everything is in small squares. The only time when I've said large squares are to be counted is gonna be per se for RR interval for calculating the heart rate of this individual. The mathematical formula will be 300 divided by the number of large squares. You can see here 6 large squares, so this will definitely work out to 50 per minute. As I said, if this guy is symptomatic, I'm definitely on for treatment. And now I want to highlight a very characteristic terminology which has come up now, that is chemical pacing. In the tachyarrhythmia section, I've talked about chemical cardioversion, like you're using adenosine for PSVT, you're giving amiodarone for ventricular tachycardia, or even lignocaine. But when I'm talking about chemical pacing, I'm trying to increase the heart rate. What are the drugs that would help you in increasing the heart rate over and above atropine? Because obviously I'm going to talk about atropine, and that everybody knows. So I want you to remember that we can give an infusion of adrenaline / epinephrine, which can increase the heart rate. Similarly, we can also be using dopamine to increase the heart rate. So when you read about chemical cardioversion, it's going to be drugs that will terminate a tachyarrhythmia. And when he says the word chemical pacing, he's talking about drugs that will increase the heart rate. I've deliberately not written atropine here because it's very obvious, but I want you to remember atropine, epinephrine, and dopamine are the drugs which are recommended. Dobutamine can also be used, but see, primary action of dobutamine is to increase the cardiac contractility as compared to heart rate. So since I'm focusing on drugs that will modulate the heart rate, increase the heart rate, pump up the heart rate, so I want to highlight atropine is going to be the number one. What's going to be the protocol will obviously be told to you. Then is epinephrine and dopamine are drugs useful for chemical pacing. With this background information, I will now be more comfortable explaining to you how a symptomatic bradycardia patient will present to you. Since the blood pressure is less, the question will initially mention regarding dizziness and pre-syncope or even syncopal attacks. Since the cerebral blood flow of the patient is reduced, the patient will not be able to answer your queries or not recognize his family members, so altered mental status. And as I explained to you, because there's going to be reduction in the coronary blood flow of the patient due to less cardiac output, chest pain can be a manifestation. So inferior wall MI itself will cause chest pain, and concomitant with that, bradycardia will worsen that chest pain manifestation. That's why we need to counteract the bradycardia component in patients of inferior wall MI by giving atropine. In fact, the only type of MI where I've used atropine per se is inferior wall myocardial infarction. Over and above this, because the heart is not able to clear the blood out properly, see, the heart has to pump blood to actually effectively keep the blood moving in the pulmonary circulation. Now, if the heart is going to malfunction, the motor is going to malfunction, there's going to be pooling of blood in the lungs. This is going to contribute to pulmonary edema. So symptoms of pulmonary congestion may develop in the patient. He can talk about orthopnea, paroxysmal nocturnal dyspnea, or any other standard features of congestive heart failure that have been deliberated or discussed by me earlier, even in the CHF topic, could be described in the question. CHF findings can actually occur in an individual. Why? Because the heart is not effectively able to keep the pulmonary circulation in a constant motion. You see, the heart has to pump at a minimal rate so that the blood continues in a forward direction in the pulmonary artery. If it's not able to do optimal function, well, you have pooling of blood in the lungs. Now, let us see, if I get a patient who's suffering from symptomatic bradycardia, what are the steps that I'll be taking for medical management of this patient. Before I talk about drugs per se, some baseline steps are to be followed. So, obviously, the first step would be to take care of the patency of the airway, because if I'm having somebody with altered mentation, tongue is falling back, airway is getting blocked, so I can definitely put in a Goodell's airway or position the patient appropriately. We can definitely put in a SpO2 monitor. This is important because if you evaluate the oxygen saturation of the patient, you can definitely start supplemental oxygen, and that's going to be good, especially in a inferior MI, because you want to provide at least some extra fuel to the ischemic myocardium. In case of the fact that the SpO2 is low, you will have to provide some kind of assisted ventilation for the patient. Apart from giving routine oxygen with help of a nasal cannula, we can be definitely using a tight fitting face mask. So CPAP or non-invasive ventilation can be used. And if required, if the patient is definitely in altered mental status to the level the GCS is less than 8, then you might even have to intubate the person, because it does not make sense to put on a tight fitting mask in a comatose patient, because if he vomits or aspirates, then obviously the aspiration component will be very fatal for this guy. Now comes the main reason why we are discussing this topic, that what are you going to do in this guy. I'm going to secure a IV line stat, and then I'm going to push atropine. Now the update here is, guys, that in my previous discussion, I've talked about atropine last year, 2020. I was talking about atropine 0.5 milligram. But according to the American Heart Association protocol, mark my words there, guys, this is one of the very important points of this discussion. According to the American Heart Association guidelines 2020, now the dose of atropine has been upgraded from 0.5 milligram to 1 milligram. So currently, remember, it is 1 milligram atropine which is given to the patient in a case of symptomatic bradycardia. You definitely can repeat this injection again after 3 to 5 minutes if required, and the maximum dose is still the same. Earlier I was saying 0. In 2020 I was saying 0.5 milligram up to 6 shots. You can be giving up to 6 shots total. That would make it 6 into 0.5 is 3. Now he's saying that you can give max of 3 shots of 1 milligram each. So that's a slight change that I definitely want you to remember. And I also want to add to your knowledge here that suppose I give atropine, if the heart rate is remaining the same, or even if it is falling, then I'll not wait for the second shot of atropine to be delivered. I'm not going to wait for that window period of 3 to 5 minutes and say, okay, now I'm going to give a second shot of atropine. If I find that the heart rate is remaining the same, or the patient's condition is worsening, or the heart rate has become lesser, let us say it started at 50, you gave atropine, you expected it to at least remain 50 or at least go a little beyond 50, it fell down to 30. Now you're not going to wait for 3 minutes with a heart rate of 30. You're going to go to the next step, that is transcutaneous pacing or transvenous pacing. I'll definitely show images to show you how a TCP or TVP would be working. But at this junction, the main message is, if he gives you an MCQ where in spite of atropine, there's no increment in the heart rate, and rather there's a progressive deterioration of the hemodynamic status of the patient, the heart rate is still dropping, you need to move on to the next step, that is TCP, transcutaneous pacing, and not the next dose of atropine. If it's remaining stable, cool. I mean, at least I won up, because atropine effect will wean away after a while. So I need to give a second shot as well. So he says, give a maximum of 3 shots, but don't wait for the next shot time to come if the person is showing a hemodynamic deterioration. Now, apart from atropine, there are additional drugs which can be used here, that is adrenaline, that is /epinephrine, and even dopamine. I can say dobutamine also, but because main action of dobutamine would be in cardiac contractility, so we need to remember regarding epinephrine and dopamine. There is a slight dose change here as well. This is optional because it is unlikely that he's going to ask you the changes in the dosages per se. But in the current American Heart Association 2020 protocol, they've mentioned it. So that is why I am just making you aware of this, that the dose of adrenaline given is 2 to 10 mics. That is epinephrine, alternatively written 2 to 10 mics per kilogram per minute. In contrast, the infusion of dopamine will be something in the range of about 5 to 20 micrograms per kg per minute. And you very well know the higher higher you will go up, there can be vasoconstriction also, and that can actually increase the work of the heart. So we start with relatively a lower dose of dopamine and gradually work our way up. And these drugs that I mentioned before you are called as chemical pacing, as I sensitized you earlier also, chemical cardioversion for tachyarrhythmias and chemical pacing for bradyarrhythmias. I repeat that again. Chemical cardioversion is for tachyarrhythmias and chemical pacing is used for management of bradyarrhythmias. Now I'm going to describe to you what's going to happen if in spite of atropine the person is not going to improve. Then I'm going to connect the patient to TCP, that is transcutaneous pacer. Well, with help of this transcutaneous pacer, we can give electrical stimulus directly via the chest wall to capture the heart. In fact, this transcutaneous pacer will be delivering electrical current to the heart to actually ensure that the cardiac contractility as well as the heart rate increases. This current will be provided in increments of 10 milliamperes, and usually when you increase the power up to 70 milliamperes, you are turning the knob here, increasing the power, the capture limit, then by 70 milliamperes, the capture of the ventricles is obtained. Now I want you to understand that the electrodes that are going to be put in this case are going to be identical to what we are going to put with respect to cardioversion, like a DC shock being done in a patient. That is, one of them is going to be just below the right clavicle vertically, and second one you can see just a little displaced away from the left nipple and towards the left axilla. So these are the two electrodes which have been deployed, and so that we can capture the heart. So the image of the electrodes per se will be same as that of cardioversion, but I said the device that we are using is different. We are trying to capture the heart transcutaneously via the chest wall, so we call it TCP, transcutaneous pacer. If transcutaneous pacer will also fail, now how will I know it is failing? The heart rate will still be dropping, hemodynamic deterioration will occur. In those circumstances, we will then have to go in for what is called as transvenous pacer. So the minimum crux of the discussion is, it is atropine. If it fails, TCP. If it fails, TVP. That's the main point, because when you read the whole algorithm, there are a lot of details present here, but the main crux I'll highlight once again is chemical pacing doesn't work, TCP, transcutaneous, and then is going to be transvenous pacemaker that would be used. Well, how do I know that the transvenous pacer is working? I'll definitely scan the ECG of the patient. This vertical lines that you can see, where I put a couple of arrows also, these vertical lines are the ones which are referred to as pacer spikes. And concomitant with the pacer spikes, I can definitely notice a relatively a broad QRS complex. That is simply telling me that the transcutaneous pacer has been able to capture the ventricles, because when ventricles will contract, that is when QRS complex will occur. I cannot ensure a normal duration QRS complex by causing stimulation from outside, because I'm using at this moment intermyocyte conduction. See, I'm not utilizing conduction system of the heart. No, I am utilizing intermyocyte conduction by the electrical stimulus provided from outside. So there's obviously going to be a broad QRS, and I can simultaneously check either the carotid pulse of the patient or I can check the femoral pulse of the patient. Now suppose he gives you a scenario that is unlikely. If he says that you have put up a transcutaneous pacer in the patient, you definitely can notice all these vertical lines coming up that I've highlighted in red. These are the pacer spikes. Before every QRS complex, there's a pacer spike that is occurring. So that's easy for you to pick up. Now the point is, yes, the computer is working. You are having an electrical representation the same, but is it causing adequate perfusion? So you need to check either the carotid artery or you need to check the femoral artery. Now here the guidelines are very interesting. He says use the femoral artery. I want to highlight this fact. He says to evaluate the efficacy of transcutaneous pacer / transvenous pacer. The data that I'm speaking is only valid for TCP and TVP efficacy. You will not be using the carotid pulsation, but you will be checking the efficacy using the femoral pulse. And the usual query of most of the doctors is that, sir, always when we are evaluating a person, especially when he is hemodynamically deteriorated, we should check the pulse which is closest to the heart, and the pulse closest to the heart is the carotid artery. Here I am highlighting, don't use carotid pulse for checking the efficacy. I'll tell you the reason why also, but that's the important technical aspect which I want you to remember. Now, why don't use carotid pulse here is because when you're doing a transcutaneous pacing, you're stimulating via the chest muscles, no, and the impulse is going inside. So this current, when it will flow via the chest muscles to the muscles of the neck also, it can cause fluttering movement in the neck muscles. TCP can contribute to stimulation of muscles in the chest wall. It can cause stimulation of muscles in the neck of the patient, and it can contribute to a fluttering movement. Because of this fluttering movement, you might get an impression that it is the carotid artery pulsation, whereas it is not carotid artery pulsation that you are feeling, it is the fluttering of the neck muscles that is occurring. I repeat the fact once again. Normally, whenever you are evaluating somebody who's having a crashing BP, you check the pulse closest to the heart, that is carotid. But in this case, he says because you have put a device on the chest which is causing electrical stimulation, it will cause contraction of skeletal muscles of the chest, contraction of skeletal muscles of the neck, so that there would be a fluttering sensation created in the chest and the neck of the person that can cause you to mistake that fluttering sensation for carotid pulsation, whereas maybe the carotid pulsation is not very much there. So he says evaluate the femoral pulse of the patient. The learning point is, or the main carry home message is, TCP and TVP, whenever you are evaluating, preferably use the femoral pulse. And this data is more applicable for TCP because it's a transcutaneous pacing. In transvenous, you are still inside the big veins of the heart. So especially for TCP, you need to remember femoral pulse to be evaluated. I mean, there are two aspects, guys, that I've said. One is, how do you know that TCP is working? Get the ECG of the patient. Notice the pacer spike, notice the broad QRS complex, simultaneously check the femoral artery pulsation. If femoral artery pulsations are plus, it definitely means that you are being able to generate a substantial cardiac output, because the heart was beating very, very slow. Now you got it back to normal rhythm, so the cardiac output or the cardiac contractility has improved. Another technical aspect that I want you to remember, especially for TCP, will be that it is not used in patients of hypothermia. I'm not writing it down because I don't think he will ask it, but generally in hypothermia there is anyway a bradycardia. See, bradycardia is a protective reflex in hypothermia. If you ask me how will you treat hypothermia, I will say gradually rewarm the body and increase the body temperature. I mean, in a hypothermia patient, if you're trying to increase the heart rate by giving atropine to the patient, it really does not make sense, because why is there a bradycardia? The body is cold, right? The SA node activity is reduced. So you should rather be focusing on giving warm IV fluids to the patient. You should be focusing on gradually rewarming the body of the patient rather than giving atropine. He says, I mean, don't shoot the messenger, treat the cause. No, the fundamental problem is hypothermia. So you will always read this statement in the textbook that transcutaneous pacing is not recommended. The word is TCP is contraindicated in patients of hypothermia. The main concept is that bradycardia is a protective mechanism in hypothermia scenario. Why? Because the body is trying to conserve whatever is the limited fuel available, because the contractility is anyway hampered. I will now be using this opportunity to also discuss a couple of ECGs of bradyarrhythmias with you, though it is discussed in the ECG and arrhythmia section as well, where I talked about both tachy and bradyarrhythmias. We are going to practice this aspect once again. So let's have a look at the very first ECG that I am currently zoomed in. You will notice that in each of these, one of the very characteristic features that you will see will be a substantially increased PR interval. And if you look at the RR interval of these patients, it's huge. So even if I don't go into counting the large squares, the point is there's definitely a bradycardia, and the PR interval of these patients is also substantially increased. Let me just count a couple of these boxes for you so that it becomes relatively easy. And you will notice that almost going up to 6, something like 5.5 to 6 is the PR interval itself. Now the PR, one small square, guys, is going to be something in the range of 40 milliseconds. So 6 into this would be 240 milliseconds. And if you count this serially, you will notice that the number of the small boxes that you're counting is almost the same, 5.5 to 6. So if PR interval is uniformly on the higher side with a concomitant bradycardia, then the ECG will be suggestive of first degree heart block. Well, what is the problem in first degree heart block? That the conduction speed between the SA node and the AV node has become relatively slow. I mean, AV node I'm showing in dotted because anyway, AV node has a decremental property, but this person could be having, let me say, Ashkoff nodules present between the SA node and the AV node that will decrease the speed of conduction. And because of this lesion, the PR interval of these patients will be uniformly prolonged, and therefore effort intolerance will be manifestation, because these patients cannot decrease their PR interval. In you and me, the PR interval is inversely related to heart rate. If you exercise, PR interval reduces, but here because of fibrosis, because of Ashkoff nodules, this PR interval will not be changing. We'll now be comparing this with the next ECG that I'm going to show before you, where you will definitely notice one, that the RR interval of the patient is not remaining constant. In fact, the RR interval is increasing. That is itself a hint, because why? You will notice that in this chart, the PR interval is definitely going to show a progressive increase or a substantial increase in duration. You will be then able to see a P wave. This is the P wave. You can see the T wave and P wave can be differentiated by the height criteria. The vertical height of P wave is max 2.5 in the limb leads, and the T wave will be 5 millimeter approximately. So this is a P wave, and now after this QRS complex should come, but there is no QRS complex. So the vertical arrow that I've shown here is the area of the dropped beats. This is the time when the person will himself put his hand on his pulse and say, see doctor, my pulse just disappeared. That is when he will start having a dizzy spell. Why? Because the ventricles really did not contract. Now, the rhythm has once again started. If you evaluate the PR interval of this patient the first time, the second time, and then the third time, there is definitely a substantial increase in the PR interval. Well, one way to solve this MCQ of Mobitz on heart block is that you should be serially following the PR interval, calculated the first time, the second time, third time, or maybe even a fourth time. It will show a progressive increase. Then there would be a drop beat, and then again a progressive increase, and the pattern will be repeated. Another way to solve this question is simply that if you just evaluate wherever is the dropped beat, the words are wherever you evaluate, wherever is the dropped beat, all you need to do is you just need to look at the PR interval after and before. Now, if you look at the PR interval after and before, you can notice that the one after will be relatively shorter, whereas the one before will be relatively more. So what I can highlight is that one way to crack this question is serial increase in PR interval, or second method is that PR interval before and after. I'm just writing slash karke. It is PR interval, if you calculate before and after, will always be asymmetrical or will be unequal. This approach will become more clear to you when I describe the subsequent ECG before you. You can notice that I've already highlighted a P wave, and after that there is no QRS complex. This particular area, in fact, I'll just use this line here to say this particular area that I have now highlighted, this area looks like almost that there is no cardiac activity. This is where the QRS complex should have come, but there is no QRS complex in the patient. So now let us evaluate what is happening subsequently in the same case. One of the important things is, if you look at the PR interval every time, there is no change. But yes, you can definitely notice a P wave happening at this particular juncture, and then again there's a area where there's no activity. That's a drop beat scenario. If you look at the PR interval again, and then even subsequently, it would remain the same. Guys, what I'm teaching you here is that the moment you are able to identify a drop beat, you are supposed to look at the PR interval before and after. Mark my words there. Whenever you see a drop beat happening, wherever in the ECG, just look at the PR interval after and before. Here you will notice that the PR interval before and after is equal. Therefore, this would be a ECG that is a diagnostic feature of Mobitz 2 heart block. I repeat the fact once again. How in a 30-second period will you identify that this is going to be Mobitz 1 and Mobitz 2? One, anyway, I mean, if you look at the huge number of squares between R and R, you don't need to waste your time counting the larger squares, because this is definitely going to be bradycardia. Anything more than 3 large squares, I mean 3 large squares is going to be, I mean, if it's lesser than 3, it's tachycardia. If it's more than 5, it's going to be a bradycardia. You can remember number 35. I mean, if the RR interval is less than 3, there would be a tachycardia. If it is more than 5, it is bradycardia. You can definitely see in this case, the number of squares are substantial, though you don't need to count them in the actual exam, but I'm just doing this activity before you. I mean, just look at that. Almost 8 large squares. That's going to be 300 divided by 8 large squares. That will mathematically work out to hardly even less than 30. So I want you to appreciate the fact that once you know it is a bradycardia, just keep a lookout for drop beats. And what's going to be drop beat? After P, there should be a flat line with no QRS. Then count the PR interval after and before. If it is equal, then it is going to be Mobitz 2, and if it is going to be unequal, it's going to be Mobitz 1 heart block. The site of lesion in Mobitz 1 heart block is going to be mainly the AV node, but when it comes to Mobitz 2, the damage is always at the starting of the bundle of his. So Mobitz 2 heart block is also called as infranodal. I repeat the fact once again, called as infranodal because it is just below the AV node, the problem. Whereas when it comes to Mobitz 1, it is nodal problem. It is inside the AV node. Now we will compare this with the next ECG, which is again very characteristic. In this one, you definitely can evaluate the bradycardia component. I mean, a huge amount of squares present between the R and the R. This is maybe going down to even 20-25 beats per minute. Apart from this, you can notice a broad QRS complex with a bit of slurring of the S wave. In none of the previous bradycardias or bradyarrhythmias have I spoken about a broad QRS present. And then in this person, you will also notice a very peculiar thing. This is P. This is a P wave. Then again a P wave is coming. In fact, when you count the number of P waves in this particular ECG, then the number of P waves would be 1, 2, 3, 4, 5, 6. But look at the number of R waves present. QRS complex is present only 3. 1. In this ECG with broad QRS, after every P wave, for every one P wave, there is one QRS complex. Here, the number of the P wave, I'm talking about the physical number, like in this particular case, if you count, six P waves, the P wave number is not matching with the broad QRS. For every P wave, for every single P wave, there should be one corresponding QRS complex. Here, the number of the P waves and the R waves will not match. In fact, I should highlight this fact: the P wave number and the R wave number is not gonna match. This is a feature of complete heart block. I'll just explain that to you. Why is this happening? Though this has been discussed earlier also. A quick look, next 30 seconds, just try to get the facts right. This is SA node, AV node, bundle of phase. In complete heart block, the lesion is in this area. If AB node is gone, then SA node will be able to definitely control the atria. So therefore, the atrial rate can be about 100 per minute. But the impulses cannot go down to the bundle of phase. So bundle of phase will control the ventricles. The ventricle rate of this guy will be only 40 per minute. What I'm highlighting before you is a very characteristic atrioventricular dissociation that can occur in patients of complete heart block. And the importance of this atrioventricular dissociation will be that because atrial rate will be more, that means there will be more P waves present. And when it comes to ventricular rate, we will look at QRS complex or R waves primarily. R waves will be relatively lesser. In fact, from this mathematics, you can definitely see that the rate at which the atrial firing is 2.5 times higher than the ventricular rate per se. So for every one R wave, there will be at least 2.5 P waves present just by mathematics. Obviously, it can't be 2.5, either it will be 2 or it will be 3. You can see here that in this particular ECG, the number of P waves is not matching with the number of the R waves. Even I can say one more fact to make you more sensitized to this information. Just look at the distance between the P and the P and compare this with the distance between R and R. Is it equal? Absolutely not. In you and me, PP interval and RR, PP interval, I mean, why do you calculate PP interval? PP interval is calculated to evaluate atrial rate. And RR interval that I've shown in blue is for calculating the ventricular rate. So I can make one more entry here, that is PP interval. Please remember, PP interval calculates atrial rate. In you and me, the PP interval and the RR interval, the atrial and the ventricular rate will always be equal. But in this case, the biggest problem will be that the PP and the RR interval, the PP, that is atrial rate, and the ventricular rate will never match. I repeat the fact once again, guys. In this particular condition, the atria will be beating 2.5 times faster. If I just go by mathematics, atria will be beating 2.5 times faster than the ventricles primarily. That is why I just put a symbol here saying that the two will not match. Learning is number of P waves and R waves will not match. Number of PP and RR interval will not match. And lots of guys say, sir, how can we expect or you expect us to remember all these things? So all I want to say is if you get a question on a bradyarrhythmia with really broad QRS complexes, you see, then it can't be premature ventricular complexes because PVCs usually contribute to ventricular tachycardia, right? Broad QRS complex I've talked about, one with respect to VT. That's going to be fast beating heart. Today I'm teaching you broad QRS with respect to a bradyarrhythmia. So that's going to be related to a complete heart block in the patient. This ECG signifies the following terminologies. Either he will write the word third degree heart block. What area is destroyed? It is AV node that has been affected. Instead of using third degree heart block, he will use the word complete heart block, or he can also use the word Stokes-Adams syndrome, and even AV dissociation as a terminology can be used. Now I want you to look at this particular ECG with broad QRS with the ones that I've highlighted inferiorly. So I'll just zoom in for your convenience sake. If you look at the first one, the characteristic thing which is present is that the PR interval is looking almost of the same duration. Yes, you are definitely able to evaluate a P wave present here, after which there should be a QRS complex, but there's a drop beat. You can identify a P wave, then there should be a QRS complex, there is a drop beat. Again a P wave, there should be a QRS complex, there's a drop beat. The vertical black shots that I've shown, the vertical black arrows are representing the area of drop beats. Therefore, the first impression of everybody will be that because the PR interval before and after the drop beat is equal, mark my words there, says the PR interval before and after the drop beat is equal, it is an example of move bits to heart block. But if you look carefully, you will notice a pattern here. The pattern is, and you need to follow my marker now, that after one P wave, after this P wave that is currently highlighted, there is definitely a QRS complex. But the next P wave is not conducted down. Let's do this again. You can notice a P wave present here that I've just marked. I'll just mark it once again. This is the P wave that I'm talking about. The highlight is, in fact, I can just zoom it here. This is the P wave. Then there's going to be definitely a QRS complex present. So what I've shown here is that the P wave is getting conducted down. That is why after P there's a Q. But look at this P wave, non-conducted. So what is happening is for every one conducted P wave, for every one conducted, I'm marking once again, this is the area of the conducted P wave. For every one conducted P wave, there is one non-conducted P wave. What I mean by non-conducted is that the atrial depolarization occurred, but ventricular contraction did not occur, no? So this ECG that I've highlighted before you is technically going to be answered as 2:1 block. I wanted you to be sensitized to the fact that move bits to heart block can actually be misdiagnosed as 2:1 block, vice versa. Why? Because the PR interval before and after the missed beat is equal and is also equal in the inferior diagram that I've highlighted. But look at what is happening inferiorly. You will definitely notice this is PR interval the same, then is same, then is same. So at least 3 were conducted, no, after 3 P waves. After every time there was a P wave, there was a QRS complex. Then subsequently there was a P wave that was non-conducted. In the previous one, what I was saying, conducted, non-conducted, conducted, non-conducted. Now see what is happening. Conducted, 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 then a non-conducted. Conducted, 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 or non-conducted. So this is going to be the second one that I've highlighted, guys, where I said conducted multiple times. Conducted, conducted, conducted. The impulse went down. Non-conducted. This is going to be presentation of move bits to heart block. So I want you to remember that move bits to heart block can be easily confused with 2:1 block, and the examiner knows that. What is the take-home message? The take-home message is the PR interval is serially increasing / PR interval before and after is not matching, move bits 1. Cool. Nobody makes a mistake. If PR interval before and after is equal, this could be a trick question. Either it is going to be move bits 2 or it's going to be a presence of what I just explained, 2:1. How would you differentiate? In 2:1 block, as the number suggests, after every one conducted P wave that causes a QRS complex, there will be one P that will be non-conducted. After every P which is conducted, there will be one non-conducted wave, that is 2:1. If you have like multiple conductions, it could be 3, it could be 4, it could be 5. But the point is conduction, 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 drop. That's going to be a presentation of move bits to heart block. So if you just go through these ECGs that I've highlighted once again, you will definitely be able to get a better sense of the bradyarrhythmias component. And yeah, obviously in the exam, speed and accuracy matters, but with repeated seeing the ECG, because if you're going to see it only once and think that you're going to be able to crack it in the end, definitely difficult, unless and until you have very good at mathematics. Because we as doctors, most of us are very bad at graph interpretations and recordings interpretation per se. I mean, I personally was very bad at mathematics, so ECG used to scare the hell out of me. But once I got after it, I said यार अब तो सीखना ही है, मैं पीछे पड़ गए. तो फिर वो जब बार बार उसको टेक्स्ट बुक को पढ़ा, मतलब पहले तो टेक्स्ट बुक में तो यार इवन मुझे मतलब फर्स्ट टाइम मैंने read, no, I could not even understand difference between move bits 1 and move bits 2. I just understood, yeah, I mean basic elementary thing was there. Yes, there's gonna be a presence of drop beats, understandable, but how to analyze it fast was a big nightmare. And thankfully in our time there was no software for image-based questions. They used to ask us aspects in theory only. But now obviously, with technology coming in, they ask a lot of new things, and they ask a lot of things from image-based perspective, video-based scenarios. So we need to be mentally ready for that. And if you just go through this data once or at least twice, you will definitely be able to score better over your rivals. My best wishes, guys. Thank you so much, and I'll see you with another topic.